Assalamualaikum. I welcome you all in this webinar that is arranged by the Pakistan Endocrine Society. I am the Dr. Sawat Anjum. I am one of the member of the Pakistan Endocrine Society. And before moving further, I would thank you so much. Now I would like to start the program. Alhamdulillah, we will soon have a holy month of Ramadan. And there is an increased prevalence of diabetes throughout the world. So it is very important for all of us to update our knowledge about the management of diabetes during Ramadan. So to spread this knowledge, the Pakistan Endocrine Society has arranged and organized today's webinar. For this webinar, we have an expert, Professor Dr. Abrar Ahmed. Sir is the endocrinologist at Lady Reading Hospital, Peshawar. Sir is also the ex-president of Pakistan Endocrine Society. Sir, welcome you in this webinar.
Thank you. Thank you, Dr.
And we have another panelist, and who is Dr. Saeed A. Meher. Sir is also the endocrinologist at National Institute of Cardiovascular Disease, Karachi. Sir was also the ex-president of Pakistan Endocrine Society. Now, moving towards our speaker. Our respected speaker is none other than Dr. Ali Asghar. Sir is the consultant endocrinologist at Liaquat National Hospital and the Medical College, Karachi. Sir, welcome you in this webinar, and over to you for initiation of the talk. Thank you, sir.
Bismillahirrahmanirrahim. Thank you very much, Sarvat, and thank you very much, Pakistan Endocrine Society, for inviting me to today's webinar. So, we'll be talking about managing diabetes in Mah-e-Ramadan, and you already have, most of you already have gone through the guidelines, and you already are doing it in your clinics. But I'll try and keep it interesting by giving you a few cases to solve, and it will be interesting, I hope, as we move on. So any discussion that we have or any interaction that we would have will be on the chat box. We'll open it in due course, and any questions that you have, you can just put that on the Q&A, and we'll try and answer as many as we can as at the end of the webinar. So let's begin. I mean, very common question that our patients ask is, can I fast during Mah-e-Ramadan? I mean, we know that people have a strong attachment to the month of Ramadan. They want to fast, and they really want to have this religious obligation. And this is a question which comes up by every diabetic who is Muslim. So in the Quran, Allah subhanahu wa ta'ala says, "O you who have believed, decreed upon you is fasting as it was decreed upon those before you, that you may become righteous." So if we look at, we have 2 billion Muslim population across the globe. There are approximately 200 million Muslims who have diabetes. That's a huge number. Remember, Pakistan has around 40 million diabetics just in Pakistan, right? And we know that 42% of patients with type 1 diabetes and 78% of patients with type 2 diabetes, they will fast for at least 15 days in Ramadan. And the CREED study showed that around 3 out of 5 diabetics will fast the entire month. So we know that diabetics will fast, and as physicians and diabetes expert obligation in the best possible manner. And as we go forward, our goal is clear. We want to allow people, we want them to fast, and we will do everything that we can as physicians to allow them to go on and follow the religious obligation. So what is the pathophysiology of fasting in patients with diabetes? Now, if you see, of course, if you're not eating, the plasma glucose starts to go down, the insulin secretion starts to go down, there is low plasma insulin levels, there are more fatty acid release, generation of ketones, and a tendency towards ketogenesis. And then, because of this low glucose, there is more glucagon and catecholamines, there is increased glycogenolysis and increased gluconeogenesis that can lead to excessive glucose or hyperglycemia as well. So again, In diabetes, we are facing different challenges in Ramadan. At one end, there can be hypoglycemia. Yet on the other hand, we can face with hyperglycemia and diabetic ketoacidosis. And because of the dehydration, we can have thrombosis. And we can see people coming up with CVA because they are fasting. So there are challenges. Now, as a physician, what we want is to keep these challenges minimized and of course, try and make our patients fast during Ramadan. So if you ask me what is the pre-Ramadan diabetes education, there are 6 important points. Risk quantification. What is the risk of my patient? Blood glucose monitoring. What time you should monitor. The fluids and dietary advice, exercise advice, medication adjustments, and when to break or rather open the fast. We'll be talk about them and we'll be moved towards cases to further discuss. But there are a lot of things that I need to see as a physician. Age of the patient, duration of diabetes, the type of diabetes, whether he has chronic kidney disease, heart disease, whether this is a pregnant patient, and all these things come into account when we manage diabetes in Ramadan. So the IGF-DAR has got 14 points. They have got 14 different questions, and they have allotted points to these different questions. For example, the first point is diabetes type and duration, the diabetes type. If it's a type 1 diabetes, the patient gets 1 point. If it's type 2 diabetes, the patient gets 0 point. Again, duration of diabetes. If the duration is more than 10 years, 1 point. Duration is less than 10 years, 0 point. Remember, the more the points, the higher the risk with fasting, right? And again, the presence of hypoglycemia. So if somebody has hypoglycemia unawareness, that is, hypoglycemia comes in, but patient doesn't know, he just goes into a coma straight away without any tremors or sweating or any other signs of hypoglycemia. So hypoglycemia unawareness, 6.5 points. Recent severe hypoglycemia, 5.5 points. And severe hypoglycemia means when you need another person to assist you during that hypoglycemic episode. Multiple weekly hypoglycemic episodes, 3.5 points. Hypoglycemia less than 1 time per week, which means maybe monthly or once or twice a month. And no hypoglycemia, 0 point. Now remember, every single point in this risk stratification is important, and we need to know about all these things when we allow our patient to fast and help them to fast actually. Level of the glycemic control. If HbA1c is more than 9, 2 points. If HbA1c is 7.5 to 9%, this is 1 point. And if HbA1c is less than 7.5, which is fairly controlled, 0 points. Again, if somebody has multiple daily mixed insulin injections, the pre-mixed insulins, right, twice or thrice daily, 3 points. Basal bolus insulin or a pump, 2.5 points. Once daily pre-mixed insulin, 2 points. Basal insulin, 1.5 points. Glibenclamide, which is a long-acting sulfonylurea, 1 point. Gliclazide or glimepiride or repaglinide, 0.5 points. And any therapy other than sulfonylurea, insulin, or repaglinide, 0 points. Self-monitoring of blood glucose. Indicated but not conducted at all, 2 points. Indicated but conducted suboptimally. Doing it but not as much as the physician wants, only 1 point. And conducted as indicated, 0 points. He's doing the right self-monitoring of blood glucose, the point is 0. Remember, more the points, more the risk, right? Acute complications, so DKA or in HHS in the last 3 months, 3 points. If there is any acute complication in the last 6 months, 2 points. In the last 12 months, 1 point. And no DKA or HONC, which is now known as HHS, 0 points. Again, macrovascular disease complications or comorbidities. Unstable macrovascular disease. Somebody is having angina on walking, right? 6.5 points. Stable macrovascular disease. Already a PCI is done, a bypass is done. Cardiologist is pretty sure everything's okay. This is 2 points. No macrovascular disease, 0 points. Now then you see the renal complications. GFR of less than 30, 6.5 points. GFR between 30 and 45, 4 points. 45 and 60, 2 points. And a good GFR of more than 60, 0 points. You won't remember all these, but as you continue to do it for your patients, you start remembering it as well. Pregnancy, not within targets. The targets are not met. 6.5 points. Pregnancy within targets, 3.5 points. Not pregnant, of course, 0 points. And then comes frailty and cognitive function. If there is impaired cognitive function or frail person, somebody who cannot get up from the bed and go to the restroom or the washroom, of course, this is frailty. Cognitive function, somebody doesn't remember things, 6.5 points. Age more than 70 years with no home support, nobody living at home, 3.5 points. And no frailty and no loss in cognitive function, 0 points. Again, the physical labor, highly intense physical labor, 4 points. Moderately intense physical labor, 2 points. And no physical labor, 0 points. Previous Ramadan experience is always very handy and helpful, right? Overall negative experience, 1 point. No negative positive experience, 0 points. And again, the fasting hours, right? If the fasting hours are more than 16 hours in the city or country where you're living, 1 point. And less than 16 hours, as will be the case in Pakistan this year, 0 point. So these are the 14 things that we need to know about our patient when we decide what we need to advise regarding fasting. So now we calculate all these points, right? If the score is between 0 to 3, this is low risk. If the score is between 3.5 and 6, this is moderate risk. And if the score is more than 6, this is high risk, right? We do a few cases, and in those cases, we'll practice this risk stratification. Even if you don't do point-wise, you start remembering what happens when somebody is pregnant with no control, 6.5 points straight away, goes into high risk, right? So what does the risk categories tell us? Now, there is a medical recommendation and there is a religious recommendation, right? So in low risk, 0 to 3 points, both medically and religiously, you are allowed to fast. In moderate risk, 3.5 to 6 points, this is a gray zone. Now, this is the zone where a good physician will help his patients make things better and allow the patient to fast. So this yellow zone is a zone where the physician has to try and make things better for his patients so he can fast. Mostly try to do this. And then is the high risk, where fasting is probably unsafe medically, and religious advice is also against fasting. Self-monitoring of blood glucose during Ramadan, we always study 7-point testing. Now, 7-point testing, of course, the 7-point testing is not for everybody. So at the start of Ramadan, you may check a few blood glucose. Then as Ramadan progresses, you know what to check and what to not check. This can be individualized, right? So again, pre-Seher, 2 hours after Seher, midday, around 12 p.m., somewhere around 3 to 4 p.m., then before Iftar, 2 hours after Iftar, and any time when the patient may deem it necessary or important, right? So again, patient does not need to do 7 glucose readings every day. I tell my patients you can do it before Seher, 2 hours after Seher. If everything is right, you can check it in the evening, 2 hours after Iftar, maybe for 2-3 days, and then you know what's going on. And then it's up to you what you check every day, maybe 1 or 2 glucose readings. And of course, we all know that checking glucose does not break fast. Dietary advice, you all know, and I'm probably not going to go into the detail, but there has to be less sugars, less oil, there has to be more fiber. Fruits are allowed in moderate quantity, of course. And this is very clearly available on the IDF website. With this, I have made the preamble, and we are going towards the first case. And I would request our team to open the chat box, because this is going to be interesting cases. I've brought the cases. You are the experts. You're going to solve it, right? So case number one, you're all with me, right? Is the chat box open, Anas?
Chat box is open, sir.
Fantastic. Yes, Kalimullah says yes. You're all with me. So I'll try and read as many comments as I can, but of course I have to go on and present as well. So first case, 38-year-old Mr. Salman. He's a banker. He lives in Karachi, the southern port city. Type 2 diabetes for 3 years. Remember, as we move on, we have to focus on those 14 points to know about our patient, right? Type 2 diabetes for 3 years. Medications, sitagliptin 50 milligram, one at breakfast, one at dinner, metformin 500 milligrams, one at breakfast, one at lunch, one at dinner. No acute or chronic complications of diabetes, fantastic. No hypoglycemic episodes, good. Checks blood glucose levels at home, but not regularly. Fasted without any problems last year. HbA1c 7.4%. And GFR is more than 90 milliliters per minute, right? So again, diabetes type and duration, and I'll see and check and see the yearbooks as well. Fantastic. So if I ask you straight away, is it low risk, moderate risk, or high risk? What will be your answer? Okay, people like low risk. Rakesh says low risk. Okay. Abdullah says low risk. Yamin, low risk. Okay, you all understand this is a low risk patient, right? So type 1 diabetes or type 2, this is of course a type 2 diabetes, 0 point. Duration of diabetes, less than 10 years. Again, a 0 point here. Presence of hypoglycemia, no. Level of glycemic control, the A1C was less than 7.5. So again, a 0 point. And then the treatment does not have any sulfonylurea or insulin or secretagogues. So again, a 0. Self-monitoring of blood glucose, he indicated, but he does not check as much as told. So 1 point here, right? Acute complications, no acute complications. Macrovascular disease, no. Renal complications, the GFR is pretty good. It was more than 60. Of course, he's not pregnant. He's Salman. Frailty and cognitive function, again a 0. Physical labor, no, he's not a laborer, he's a banker. You may call it a laborer, but I won't. Previous Ramadan experience was good. Fasting hours, he lives in Karachi, is going to be less than 16 hours. So he just have a score of 1.0. Now remember, in risk categorization, you ask all these 14 things, consider all these 14 things, and that is where I want to focus today. So of course, this gentleman, you're all correct, he is low risk. And low risk means that both medically and religiously, he is allowed to fast. But should we send him back home? No. We need to adjust his medications. Now, how to adjust his medications? I'm sorry, मैं आप लोग चैट पे लिख रहे हैं, लेकिन मैं पढ़ शायद नहीं पा रहा पूरी तरह, कोशिश करता रहूंगा साथ साथ. So again, how will you adjust medications, right? He's on sitagliptin 50 milligrams, one at breakfast, one at dinner, and metformin 3 times every day. What happens to the sitagliptin? Okay, what happens to the sitagliptin? So sitagliptin, of course, you don't need any dose adjustment. The sitagliptin remains same. Fantastic, no change. Fantastic. One at seher, one at iftar. Sitagliptin remains the same. And very good, Kalimullah, metformin, 500 milligrams at seher, one tablet, and the lunch tablet, you move it to iftar. Fantastic, Dr. Maida Jabin. Good. So again, sitagliptin, you don't need any adjustment. But remember, if some medication is once daily, that once daily medication will automatically go towards iftar, right? Whatever is once daily, sitagliptin or glimepiride or insulin, once daily goes to iftar. So again, changes to metformin dosing during Ramadan. So if there is once daily dosing, take at iftar. If there is twice daily dosing, of course, take the bigger dose at iftar, the lower dose at seher. If there is 3 times daily dosing, the lunch dose goes into iftar, but do not exceed 1000 milligrams of metformin at one time. Remember, at one time, you cannot exceed 1000 milligrams of metformin. DPP-4 inhibitors, they do not require any treatment modification during Ramadan. But remember, a once daily DPP-4 will also go to iftar. You're all ready for the case number 2. As we move forward, the cases will get difficult, right? And we'll move and see what happens in the next case. So are you all ready? Yes or no? Moving to the next case, right? 45, okay, yes, everybody writes it. Tuba, Yasin, Khurshid, Sandeep, good. You're all ready. 45-year-old Miss Aisha, university teacher, living in Lahore. So this is from Lahore, right? Type 2 diabetes for 11 years. She has neuropathy and retinopathy, microvascular complication. Medications, 500 milligrams metformin, one at breakfast, one at dinner, and glimepiride, sulfonylurea, breakfast, one tablet. There is no acute hyperglycemic complications, no macrovascular complications, mild hypoglycemic episodes once in last 1 month. Okay, once in last 1 month. She checks blood glucose at home regularly. She had to break 3 fasts last year due to hypos. A1C is 8.6. You all know that's uncontrolled. GFR is 76. Now, if I ask you which risk category this patient will go into, high risk, okay. Okay, people write high risk, high. Okay, let's see. So you see, even I would have said high. Somebody says, Rubina says moderate. Everybody says high. Let's see and see. Let's go and see the chart, right? Let's see what the chart says, okay? So type of diabetes, of course, it's type 2 diabetes, 0 point. Duration was more than 10 years, 1 point. There is hypoglycemia, but less than 1 time per week. इनको महीने में 1-2 बार हो रहे थे. So less than 1 time per week, 1 point. Level of glycemic control is between 7.5 and 9. Again, a 1 point. Type of treatment on glimepiride, 0.5 point. Self-monitoring of blood glucose, she conducts as indicated. There is no acute complications. Macrovascular disease is not there. She has microvascular complications, right? Renal complications, the GFR was more than 60. She is not pregnant. Of course, she's not frail as well. There is no physical labor that she has told us about. Previous Ramazan experience was not that good. Fasting, Lahore, less than 16 hours. The score is 4.5, and she falls in moderate risk, right? So sometimes when we see the patient, we just can't grab all these 14 points together and put the patient in a risk category. But if you have this in hand, you can quickly see what the risk is, and then we move accordingly. So with yellow light, it is incumbent upon us to try and allow this patient to fast. Again, medically, fasting is uncertain. Religiously, also, fasting is preferred, yes. It depends on what the patient and doctor decide after the whole condition. So now how will you adjust her medications? She is on metformin 500 milligram, 1 in the morning, 1 in the night. Glimepiride 4 milligrams at breakfast. Now the question is again, you know metformin, right? It will remain the same, 1 at breakfast, 1 at dinner. What about glimepiride? Where does glimepiride go from here on? Yes, what about the glimepiride, right? So metformin remains the same. Glimepiride goes to iftar. Okay, some of you are reducing the dose of glimepiride. Others say go full dose of glimepiride at iftar. Look, if there is anything that is once daily, anywhere, remains full dose and goes in iftar, right? Okay. And remember, the A1C is not too good as well. So you can argue that maybe the dose needs to increase, but of course you're not increasing, you're just pushing glimepiride 4 milligram to iftar, right? So again, if you see the changes to sulfonylurea during Ramadan, yes, somebody writes maybe increased metformin. So we have those cases coming up in future, the last 4-5 cases, right? Again, glimepiride goes to iftar, remains the same. Any once daily dosing goes to iftar. So again, just see changes to sulfonylurea dosing during Ramadan. So any once daily dose goes to iftar. Any twice daily dose, the morning dose goes to iftar. The night dose comes to seher and gets reduced. by 25 to 50%. And then the older sulfonylurea, glibenclamide, should not be used in Ramadan. Only gliclazide or glimepiride, which is the advanced modern day sulfonylureas, should be used. So again, we have done 2 cases, and as we move forward, the scope will get broader as we move. We are now on to case number 3. Case number 3, 47-year-old Mr. Bhatti, office clerk living in Peshawar, the city of our wonderful friend and past president, Dr. Ibrar Ahmed, who is the panelist with us today. This man, Bhatti Saab, is from Peshawar. Type 2 diabetes for last 12 years, goes to his 8-hour job daily. Fantastic. 8 hours is quite good, right? Medications, the triple combination, AMPA, Lena, metformin in the morning, 1 at breakfast, and pre-mixed insulin, 30 units at breakfast, 20 units at dinner. No acute complications of diabetes recently, and no macrovascular disease. No recent hypoglycemia, checks blood glucose levels at home regularly, fasted without any problems last year. His A1C is 7.9, GFR is 62. So important is to measure the GFR. So important to take up what happened in last Ramadan. Imagine somebody you say, don't fast, and he says, oh, doctor, come on, I'm fasting 30 days every year for the last 5 years, right? So again, moving forward, what do you all think? What will be the risk category for this particular patient? Low, moderate, high risk. Somebody's also calculated score. Fantastic. You're going ahead of me. Moderate. Okay. Shaban says moderate. Kaleem says moderate. Hassan says high. Okay. Good. Rubina. Okay. Everybody is posting. So I'll just move forward and see what happens next. So again, type 2 diabetes type. Of course, this is type 2 diabetes, 0 points. Duration is more than 10 years, 1 point. Patient does not have hypo, 0 point. A1C between 7.5 and 9, 1 point. Multiple daily mixed insulin injection, he takes 3 points. Conducted self-monitoring done as advised, 0 point. No acute complications, 0 point. No macrovascular disease, 0. Renal, the GFR is more than 60, 0 point. Of course, not pregnant, Mr. Bhatti. No frailty that he has told us about. No physical labor. Previous Ramadan experience was very good. And again, Ibrar Bhai would agree that the fasting hour in Peshawar will also be less than 16 hours. So this is a risk score of 5.0. He falls in the moderate category. And again, the onus lies on the doctor now to try and push this patient in the green zone, right? So again, how will you adjust his medication? Now, I will ask systematically, what about the triple combination, the AMPA, Lena, metformin? Where does it go? Should we make it half? Should we just change it? At iftar, Naghmi Majid says at iftar, Yamin says iftar, Kaleem says triple full dose iftar. You all know it, right, Rakesh? Very good. Fantastic. So the triple combination goes to iftar. Next, what about the insulin? What about the breakfast dose of 30 units? Where does that go? Breakfast, 30 units of insulin. What to do about that? Okay. Okay, to iftar goes half. Okay, so the breakfast dose goes to iftar as a full dose. So the breakfast 30 units will go to iftar, right? And the night dose of 20 units will move to seher and become half. So it's very simple. The morning dose, take it to iftar straight away, 30 units. The night dose comes to seher and becomes half. But this is not something that has come in the Quran, right? You can, of course, change it according to the patient's habits. Remember, SGLT2 inhibitors, very low risk of hypos. No adjustments are required during Ramadan. But remember, if you are giving it once daily, then that has to be given at iftar, right? And any medication that is once daily simply moves to iftar as a full dose. TPP4 inhibitors, we already discussed, you do not require any treatment modification. What about premixed insulin? Once daily dosing, wherever it is, once daily, breakfast pe hai, ke lunch pe hai, ke dinner pe hai, take the full dose at iftar, same dose. Twice daily dose, the morning dose will go to iftar as a full dose. The night dose will come up to seher and become half. You reduce it by 25 to 50% according to your patient blood glucose levels. And if the patient is taking a lunch insulin, of course, that needs to be omitted. Oh, on Mah-e-Ramadan, day 12, the patient comes back, right? Now, pre-iftar blood sugar of Mr. Bhatti is 208. Come on, guys. He is back. Iftar se pehle sugar high hai. 208 is high. Which insulin dose you would like to increase? The morning dose or the night dose? The seri dose. Fantastic. The seri dose was 10 units. How many dose, Amreen, you want to make it? It's 10 units, 14, 20, 14, 20. Let's see what the guideline says, right? Let's see what the guideline says. Now, this is the dose. 10 at seher, 30 at iftar. You want to increase the seher dose, right? Okay, let's see. I have made it 14. Okay. Now, again, this is not, these are just guidelines. Right? What the guidelines say is, if the pre-seher or the pre-iftar glucose is between 90 and 126, no change required. Less than 90, at iftar, reduce the seher dose by 2 units. Less than 70, reduce the dose by 4 units. And again, if the sugar is more than 126 before iftar, increase the seher dose by 2 units. If the glucose level is more than 200 before iftar, increase the morning dose by 4 units. Here, it was 208 before iftar, so I increased it by 4 units following the guidelines of the IGF. But remember, this is your patient, and you can make it a little up or down as you know your patient better. Case number 4. Are you all ready? Yes. I need a couple of yes before I go on to the next case, right? So, okay. Okay. That's enough. Yes, we're moving to the next case, right? So again, the next case, 25-year-old Miss Ikra, university student living in Islamabad. Type 1 diabetes for 12 years. Type 1 diabetes, whenever it comes to the mind, we think, oh, probably type 1 diabetes, they cannot fast. How can type 1 diabetes fast, right? I mean, this was the concept few years ago, right? So Ikra has developed retinopathy. She's on basal bolus, Clargine, 30 units at 10 p.m., regular insulin, 10 at breakfast, 10 at lunch, 10 at dinner. No acute complications of diabetes recently, and no macrovascular disease. Mild hypoglycemic episodes once or twice a month. Checks blood glucose levels at home regularly. Kept 5 fasts without any problems last year. Such an important piece of information. HbA1c 7.3, not bad at all. GFR is good, more than 90. What do you think will be the risk category of Ikra? High risk. Taimur says high risk. Tuba says high risk. Okay. Abid Razaullah says high. Naseeb says moderate. Ghulam Raza says high risk. Let's go on and see what's going on, right? Okay, so let me move forward my screen. Let's categorize type 1 diabetes, 1 point. Duration is more than 10 years. Another point, there is hypoglycemia, but quite less, once or twice a month. So that's hypoglycemia less than 1 time per week, 1 point. A1C is good, less than 7.5, 0 points. She's on basal bolus insulin, 2.5 points. She's doing self-monitoring and no complications in the last 1 year. No macrovascular disease. GFR was very good, more than 90. She's not pregnant, not frail, no physical labor. Previous Ramadan experience, 5 fasts and no problem at all. Good experience, right? Fasting hours in Islamabad is less than 16. And the risk score is 5.5. She falls in the moderate risk, right? So every type 1 diabetic, initially, we always say, oh, high risk. Things have changed. My type 1 diabetes patients, they fast. Of course, it takes time. In my patients, it takes 2 to 3 years before I get them ready to fast. Of course, it has to be with the safety, right? So again, the yellow zone, right? Let's see, we'll explain all the risks, right? There can be TKA, there can be dehydration, but with education, type 1 diabetes people do fast. Majority of my type 1 diabetes patients have been fasting. What we need to maintain is blood glucose level and good hydration for them to fast. So how will you adjust your insulin dose? Glargine is 30 units in the morning. What do you do with glargine dose, right? Somebody asking for the triple combination. We've already done the case that goes to iftar, right? Come back to the case. What about the glargine dose at 30 units in night, right? 30 units of glargine at night. What do we do with the glargine dose? No change, no change. Rashid says, refuse, okay? Stay same. Good, fantastic. So now you see the control, right? How the control is. Okay, what about the regular dose? The lunch dose, of course, goes away. What should be the iftar dose? Can you tell me the iftar dose, please? Iftar dose. No change means 10 units, okay? What about the seri dose? 10 units lag rahe hain seri pe. What about the seri dose? 18 units at iftar. So the current dose at dinner is 10 units, right? Sehri 10 and iftar also, probably people say 10 as well. Okay, let's move forward and see. Okay, let's move forward and see, right? What the guidelines tell us. So 30 units now become 24 units. I have reduced it by 20%. And the morning sehri dose again reduced by 20% to 8 units. Iftar dose remains the same. We talk to her and she takes a light iftar, the same as her dinner that she takes every day. Look at the guidelines from the IDF. Basal insulin, if A1C control is less than 7.5, reduce basal insulin by 20%. 30 को हमने 24 कर दिया. Take at iftar or late evening. Again, poor glycemic control, I would have gone on with the same dose or rather increased a little bit. Prandial insulin, again, patients on fixed doses, the seher dose, the night dose goes into seher, reduced by 20%. The morning dose goes to iftar, remains the same. Now remember, this is a case that I've discussed because of the many things that goes on for type 1 diabetics. अब मुझे याद है आज से 10 साल पहले type 1 diabetics के लिए simple no होता था. Things have changed dramatically and we have also benefited from these information. The last couple of cases, you're all ready, right? Are you all with me? I need a quick yes to move forward, right? Are you all there, awake, alert? So the last cases, Naseeb, Shuaib, Zaida, you're all ready. Fantastic. The last two cases are a little difficult. We'll take another 10 minutes and finish off probably. 65-year-old Mr. Faraz, retired school teacher, lives in Hyderabad. Our moderator, Sarvat Anjum, she is also from Hyderabad. Sarvat, this is your case, right? Type 2 diabetes for last 8 years. Glargine, 30 units at 10 p.m. Metformin, 850 milligrams, one at breakfast, one at dinner. Stable coronary artery disease. No acute complications of diabetes. No hypoglycemic episodes. Doesn't check blood glucose levels at home at all. Oh my God. Fasted without any problems last year. Fasting is 191, which is high. Random is 206. A1C is bad, 9.1. GFR is 67. Can you all tell me straight away? You've already written moderate risk, high risk, moderate risk. Okay, I agree. Probably falls in one of these two categories, right? Let's move forward and see where he goes from here, right? I'll be a little quick with the chart. Type 2 diabetes, duration is less than 10 years, no hypos, A1C is bad, 2 points. He's on basal insulin, 1.5 points. Monitoring, he doesn't check at all, 2 points. No complications, no macrovascular disease. He has a stable macrovascular disease, so 2 points for that. GFR is more than 60. Of course, he's not pregnant. No frailty or loss in cognitive function, no physical labor. Previous Ramadan experience is not bad at all. Fasting, of course, in Hyderabad, Sarvat would agree, is less than 16 hours. The score is 7.5. You all are fantastic. You already judged. This is high risk. What should be the advice? Now, this is the advice flashing on your screens. How many of you would allow this patient to fast? Remember, there are still 3 weeks left in Ramadan. Do you think we can make this patient fast? Yes or no? I need in the chat box. Not at all. No fasting. No. Yes. The audience is split, right? So at the moment, no. At the moment, the guidelines seem no. But of course, we have time in our bag, right? Now, what we can do? Fantastic. Somebody writes, will advise him to monitor RBS and follow up 3 days before Ramadan. Okay, we still have 3 weeks. At the moment, it's red light. We'll tell the patient, ji, abhi to aapko ijazat nahi di ja sakti roze rakhne ki, but we have still 3 weeks left. We can make things better. Go back to the case. What can we improve in this particular slide? इस स्लाइड में, इस केस में क्या इंप्रूव कर सकते हैं हम? आप गौर से इसको पढ़ें एक एक चीज को, तो आपको नजर आ जाएगा. Oh, great. SMBG, sugar check, right? Fantastic. You can improve that. Go back home, check your sugars regularly, come back, and maybe we improve the doses as well because his fasting is high, right? So if, just see on the right of your screen, if this self-monitoring of blood glucose, we take it from 2 to 0, the next score in 2 weeks' time that he has is 5.5, and he goes straight to the moderate risk category. But that is only one thing that we'll do for him. How will we adjust his medications, right? Now, remember, 3 weeks are left. Uncontrolled diabetes. We have to increase the dose somewhere because the A1C is 9%. We know that. Very good. You have already told the answer and you are ahead of me. Fantastic. Fantastic audience, right? So again, adjust medication first for the usual non-fasting days and then Ramadan. So again, just have a look at this. Fasting is 191. In this prescription, what would you like to increase, right? What would you like to increase in this prescription? You've already written increased dose of glargine. It's a basal insulin. Make Lantus 34. Okay, you want to increase glargine to 34. Let's see what I've done, right? So I've gone on and increased the dose of glargine to 40 units because the fasting was 200. Now, this is up to you. You can go to 36, 38, 40. Of course, the weight of the patient is a factor, how much insulin resistance is there. You know your patient well, how he has fared in the last few years' time. So, of course, the important point to understand is the 3 weeks are left. SMPGs can be made better. Glucose levels can be improved, and he may be allowed to fast. Now, this is the dose for the usual days. Glargine 40, metformin 850 twice daily. What about Ramadan? What should be the dose for Ramadan? Remember, you have already increased the dose of glargine for his uncontrolled diabetes. अब रमजान के लिए क्या dose set करेंगे? Yes. What should be the dose? Yes. Continue same. Now you have adjusted it for the uncontrolled diabetes. From 30, I made it 40, right? Now we have to follow the rules for Ramadan. Ramadan के लिए नीचे आना पड़ेगा. Again, somebody writes same after increased dose. Somebody writes reduced dose. Okay, let me tell you. So this is 40 and it will again go down for Ramadan. The dose will go down to 32. So from 30 we went up to 40 for normal days because of his uncontrolled diabetes. But Ramadan rules remain intact. Somebody who is now on 40 has to go down because of Ramadan, right? So what is the rule? So glargine or detamir or whatever is the long-acting insulin, the dose gets reduced by 15 to 30%. And it should ideally be taken after iftar, but you can take it at night as well. But iftar, because the next day before iftar, the dose is getting low to avoid hypos, right? So reduce glargine by 15 to 30%. Now remember, this is Ramzan adjustment, right? And again, short-acting insulin, we have already discussed. The morning dose goes to iftar. The night dose goes to Sehri, becomes half. Oh my God, the patient comes back again, right? You're already, right? Somebody says we can reduce glargine to 36. I agree. It's up to you. You decide. These are just guidelines to guide you and me, right? Now in May, Mah-e-Ramadan थे 13, 30 कर दिया था हमने, 32 dose कर दिया था. Pre-iftar blood sugar of Mr. Faraz is 81. He comes to your clinic, he says, oh doctor, today iftar, before iftar, my blood glucose was reduced 81. Reduce further. How much should you reduce? That's the question, right? So this was it. This was 32. And what have I done? I have reduced it to 30. You can make it 28 or 26. But what the guideline says is extremely important. Remember, before iftar, if blood glucose is less than 90, reduce by 2 units. Less than 70, reduce by 4 units. So you have guidelines to guide you. But of course, you can do it according to your own thinking and experience as well. Somebody will ask about Sehri meal as well, and then it is glargine. Fantastic. because I want to give the crux of all this, these risk factors and how to keep an eye on them. We did not talk about diet. It's a whole topic. We should keep a whole 1 hour webinar on this, right? On Mah-e-Ramadan, day 28, patient comes back again. 4 p.m. blood glucose is now 62. What to do? He calls your clinic, your nurse answers, Marfood Anwar, very good. You open the fast to break the fast. And we need to tell the patient that this is allowed by religious scholars across the board, right? Recheck blood sugar, again rechecks, the sugar is the same, break fast. So that's very important that people need to be told that there is no harm in it. Ulama and Islam has been very kind to allow us to take care of our body, right? And again, if blood glucose is less than 70 or more than 300, the consensus of Muslim scholars from many countries, more than 13, say open the fast, and you can keep it again at a later time after Mah-e-Ramadan, right? With this, we move to the last case of the day. 50-year-old Mr. Rehan, you're all with me. And I hope you're not tired. This is the last case before we go to our lovely panelists, right? 50-year-old Mr. Rehan, a fruit vendor in Quetta. So we have gone all the way to Quetta, right? Type 2 diabetes for last 8 years. He never missed Ramadan fast in last 3 decades, right? Now, see, somebody who has never missed a fast in last 3 decades, you and me probably won't be able to stop as fast this time as well, right? We need to know that we have to allow him to fast. How? Let's make the choices, right? So Vildagliptin, breakfast, 1 tablet, dinner, 1 tablet. Pre-mixed insulin, 70-30, breakfast only 30 units. No acute complications recently. Hypoglycemic episodes are there once or twice a week. Oh, checks blood glucose. And I asked him, and of course, he was not taking his meals properly, missing his snacks as well. So we would advise that accordingly. We advised him that, right? Checks blood glucose levels at home irregularly. Again, most of the time he's on the streets. Adamant on fasting this Ramadan. Doctor साहब 30 साल से रख रहा हूं, अब भी रखने. Fasting is 112, random is 246. That's bad. A1C is 8.9, not good at all. EGFR is 67. What do you think? What category this patient will fall into? High risk, high risk. Okay, you guys know this is high risk. And patient is adamant to fasting, right? Most of you think this is high risk, right? Let's go on and see what happens. Okay, interesting. So again, I'll quickly go through it, right? You are already an expert in this chart. Type 2 diabetes, 0. Duration of less than 10 years, again, 0 points. He has hypos, multiple weekly hypos. The reason is he was missing his meals, missing the snacks, not taking care of his diet. A1C between 7.5 and 9, 1 point. He's on once daily mixed insulin in the morning. We know that. Self-monitoring is not doing as advised, but not doing as advised, 1 point. No acute complications, 0 point. No macrovascular disease. GFR is just barely more than 60, 0 point. Of course, he's not pregnant. No frailty, no physical, no very hard physical labor. He's a vendor. It doesn't move a lot. So I asked him, there is no physical labor involved, right? No negative or positive experience. So again, 0 point. In Quetta also, the fast is less than 16 hours. You guys are correct. This is high risk, right? Now again, somebody is high risk. You're going to tell him, okay, you fall in category high risk. You cannot fast. But remember, he has fasted for all his life, 30 years at a stretch. He has not missed a fast. We still have 3 weeks to go. We can change things. What can we change in this? This is what I want you to pick up, right? What can we change? Okay. Medication adjustment can become a little difficult, right? Now, his random glucose is high. Fasting is not that bad, right? And he's already taking 70-30 insulin at breakfast, right? What can we do? Monitoring. Very good. So glucose monitoring. He checks blood glucose irregularly. Maybe we can make him regular here. Fantastic, Tuba Sheikh. Regular sugar monitoring. Ambreen Salman, SMPG, dietary counseling, change of regime. Fantastic. So we know that we can try and amend on a few things. What can we do? What will be your advice, right? Okay, let me see. Okay, now just see, can we reduce his hypos in the next 2 weeks, right? He currently has multiple weekly hypoglycemia. See on the left side of the picture, left side of the slide. Can we bring it down to 0 in next 2 weeks? Move on to the right side. Point number 6. Can we improve his glucose monitoring in the next 6 weeks? Next 2 weeks. And then the score becomes 3. And somebody who was on high risk now suddenly goes on and becomes low risk because of your effort as a doctor, right? Somebody says shift to premix 50-50 basal bolus regimen. Everything is open for you. If you feel you can change things at this stage, yes. I personally, in the last few weeks' time before Ramadan, I'm more adamant, more inclined towards making adjustments in the current regimen and not change the whole regimen. Sometimes it can take time to adjust on the new regimen, right? But you are experts. Of course, you can try and do different things if you think you can get that settled down in next few weeks. But in this particular patient, reduces hypos, more active monitoring, and now he's low risk. How to adjust his dose, right? Now, how to adjust his dose? Again, very important question. So again, adjust medications. Now, again, 3 weeks are left. We have to adjust his dose. Diet, I've already advised. Please take proper 3 meals and 3 snacks to reduce your hypos. Remember, he takes 30 units in the morning. Look at his sugars. Fasting is 112. That's not bad at all. His random is 246. Fantastic, Naseeb. You tell me that go to 36 units of premix in the morning because his after breakfast dose at after breakfast glucose level is high. So we will increase his morning dose of premixed insulin. Fantastic. I concur and agree with you. Tend to agree with you. I made it 38. You could have made it 36 as well. No problem. But this is for the non-fasting days. And then Naseeb says, Dr. Ali, you are in Karachi, I'm in Quetta. I won't be able to come back. Okay. We have good doctors in Quetta as well now. Fantastic doctors there, I must say. So again, what about he comes back, hypos have reduced. He's now checking his glucose levels, which are pretty fine. How you adjust the medications now? Vildagliptin, 1 in the morning, 1 in the night. What would you do for Vildagliptin? What would you do for Vildagliptin? Would you make an adjustment? Adjustment needed? Yes or no? Same. Nothing for Vilda. Fantastic. Same dose. What for the premixed insulin? जो बताएगा उसके लिए इनाम है. इनाम सिर्फ आपके लिए दुआ हो सकती है virtually. Physical इनाम तो नहीं आ सकता आप, ठीक है? So premixed insulin 70-30, 38 units at breakfast. Where does this premixed 38 units go? Iftar. Zahida is the first person to answer. Tuba says iftar. Maida says iftar. Oh, you all are there. Abu Bakr says Taimur. Fantastic. Once daily, whatever is once daily goes to iftar. That's the rule, right? So you shift the premix 70-30 to iftar 38 units, right? And look at this. Once daily premixed insulin, shift to iftar. Twice daily premixed insulin, the breakfast dose goes to iftar full dose. The night dose goes to sehri, becomes half. And I think with this, I would thank you all. And I really thank you all for being so attentive and so interactive on Zoom, which can be difficult. I mean, I did not feel for a moment that it was Zoom. You had been so active, all of you. Thank you so much, all of you, for attending and being that interactive and making me enjoy the last 50 minutes or so. Thank you very much once again, Pakistan Endocrine Society, Sarvat Anjum, and our very esteemed past presidents of Pakistan Endocrine Society, Professor Saeed Meher and Dr. Ibrar Ahmed, for being here with your expert guidance. Thank you very much, all the participants as well. Thank you.
Thank you so much, sir, for your excellent and interesting case-based discussion of the topic. Sir, I must say that every participant must have to agree that you discuss each and every case very well, that no question is already been left. So despite that, if there is any question, then please keep it on the question answer session or question answer box so that we can answer. If any of the participant have any question, then they can ask in a QA box or in a chat box. So if there is no any answer, any question, then we will have to move towards our panelist. And I would like to request our panelists to have their expert opinion about the talk.
Assalamu alaikum. Thank you, Dr. Sarbat. First of all, जैसे Dr. Ali ने कहा कि it was a very well attentive or very well responded session. इसमें ज़्यादा जो मसला वो होगा वो from हमारे स्पीकर डॉक्टर अली की तरफ से था और एक पार्टिसिपेंट्स हमारे they were very good. So the involvement of participants or the involvement of speaker with them was excellent. So I must say during just to add a few a point or two to this excellent presentation of Dr. Ali, Ramzan is a name of modification. So if you have a lifestyle change, lifestyle modification in your daily activities, so you must have this daily drug doses modification of your patients. Modification ही करनी है इसको परमानेंट बेसिस पे तो नहीं होता लेकिन it is modification. So just to modify your and individualize your patient's treatment, and inshallah it will be good. So just to add on, वैसे तो कुछ कहने की ज़रूरत नहीं है, add on होने की ज़रूरत नहीं है. It was an excellent talk, an excellent 50 minutes. Thank you.
Thank you so much, sir. Before moving to our second panelist, I would like to ask some of the questions as they are posted on a QA box. So which guideline is the DAR guidelines you followed, 2021 or 2025? Sir,
That's the 2021 guidelines of DAR.
okay, sir. Another question is, any thoughts on reducing the SGLT2?
Sir, what would you like to ask the panelists or you are asking me?
Sir, I would like to ask from the panelists as well as from you.
Okay, so SGLT2 inhibitors, if you ask me, SGLT2 inhibitors, I usually give it in the morning, right? Because we know with SGLT2 inhibitors, there can be increased urinary output. So I personally am very much inclined to use SGLT2 inhibitors in the morning. And I told you that whatever is once daily goes into iftar, right? So once daily SGLT2 in the morning straight away goes to iftar. But there are people who are taking twice daily SGLT2 inhibitors as well. And you can give it on seher and iftar. There is no contraindication to that. But the question that Mujtaba has asked is, any thoughts on reducing SGLT2 inhibitors? So of course, the dose of SGLT2 inhibitors, and we use the lower doses for SGLT2 inhibitors for diabetes control, usually for empagliflozin, it's 10 milligram, for dapagliflozin, it's 5 milligrams. So I would personally think that it should be there in iftar, but if you're giving it in seher, it can be difficult for the patient because the patient can have a couple of times more urine output and that can put him into dehydration. So try and avoid using SGLT2 inhibitors in seher. You can definitely use it at iftar without reducing dose.
Thank you so much, sir. Another question I would like to ask from our panelists that SBA1C cutoff to start the basal bolus regime. This is the question by Muhammad Abu Bakar.
बेसिकली तो ये इस क्वेश्चन में ये है कि ये ड्यूरिंग नॉर्मल बिहेवियर में तो आप ऐसा कट ऑफ कुछ दिस इज देयर इज नो सच कट ऑफ कि भाई आप 8 पे भी शुरू कर सकते हैं 9 पे बट इन आवर सेटअप इट शुड बी मोर देन 9 एंड उसमें आप इसका बेसल बोलस रेजिमेन शुरू कर सकते हैं यू कैन स्टार्ट विद इट इफ अ पेशेंट इज सिम्टोमेटिक पेशेंट के डेली जो शुगर के वो हैं चेक्स जो हुए हैं जो SMBGs के लेवल हैं they are not controlled so you can start if more than 9 but the basal bolus regimen had different in different conditions you start जैसे pre-surgical patients में आप अपने pregnancy में that ये चीज़ें आप जल्दी स्टार्ट कर लेते हैं एंड ड्यूरिंग इसके कट ऑफ्स का तो उसका वही है 9 अनकंट्रोल शुगर अनकंट्रोल सिम्टम्स अनकंट्रोल डायबिटीज स्टेटस उसके ऊपर आप देन यू कैन डिसाइड ऑन इट थैंक यू
Thank you so much, sir. Sir, another question is there from the panelist and the speaker as well. What to do with the oral semaglutide, which needs to be taken 30 minutes before the meal to give at Sahu? This is the question by Rabia Basit.
I think we have the expertise of Professor Saeed Meher with us. Professor Meher, I would like you to answer this question.
Thank you, Ali, for your kind invitation to join this an excellent webinar. Congratulations. As always, your talk is really an beacon light for the patients, for our general practitioners. Now, for the oral semaglutide, this is something which is still available not in Pakistan, but we do use it in some of the patients who are taking it from the out of the Pakistan. Now, there are certain issues with it, like the absorption taken early. Then some of the patients may develop the GI symptoms. So I think so if it is available in Pakistan, then we when use it on a larger scale, then we may have the more experience of it, then we can tell you exactly. But it is available. It can be used in patients who are actually obese, whose diabetes is not controlled. Then oral semaglutide is an option in these patients.
Thank you so much, sir. So another question is about the physical activity in Ramzan. If someone has a hard worker and he is also doing the Taraweeh prayer, so what is your advice about the physical activity? And this question is from our panelist.
If someone has got the diabetes and ischemic heart disease, he is having the Taraweeh, then I will say that his exercise in a Ramadan is maaf. I think so that's enough. If he's taking control of actually his diet and other things, then if he's having Taraweeh, then I think so there is no need to do some extra something which may have got negative impact. For example, as you said, this patient already has got the ischemic heart disease also. So I think so the Taraweeh is enough. Diet control should be maximally can be done, which is usually sometimes slipped out in Ramzan. But I think so after Taraweeh, there is no need of extra exercise.
Thank you so much, sir. Sir, there is another question from the Rubina Faisal about the sickness rule in Ramzan.
But can you repeat it? The question I have to understand that.
Sir, the question is about the sick day rules in Ramzan.
Now, sick day rules usually are the same, whether they are in Ramzan, they are not in Ramzan. You don't have to stop your insulin, this or the oral medications, and keep a strict eye on your blood glucose levels. God forbids, if your sugars are becoming very low or very high, this is the time when you have to see your doctor. Another thing which Ali has also mentioned, that before Ramadan, everybody should see his or her doctor, that they should advise whether they fast, whether they do not fast, and they always need the adjustment of the medications. So the sick day rules usually are the same, which are the other, but again, a strict check on the blood sugar levels, and if they are wide fluctuations, then it's better to see your doctor to adjust your medications accordingly.
Thank you so much, sir. Sir, this this is a question from the Dr. Ali Asghar. Role of once weekly pralagliptin or terzepatide in Ramzan.
Though I'm not a very big fan of the once weekly TP4 inhibitors, trelagliptin, but the dose will remain the same for trelagliptin. I also see people asking about tirzepatide and people asking about GLP-1 analogs. Again, whatever it is, once weekly or once daily GLP-1 analogs, they continue. That needs to be continued during Ramadan. The only point is for us to understand is that Few weeks before Ramadan, treatment adjustments, adding new medications should always be avoided because you see with the tirzepatide, which is still not openly available in Pakistan, but other GLP-1 analogs that are there, we know that they can cause nausea in the initial part of their administration. So, of course, any GLP-1 analog that you start to your patients, that should be done at least 2 months to 3 months before Ramadan because the dose gets escalated in the first few weeks, 2 months. So, for both GLP-1 analogs and for the once weekly DPP-4 inhibitors, you don't need any dose adjustment for Ramadan.
Thank you so much, sir. Sir, this is a question, another question that is on SGLT2 inhibitors in patient without diabetes. I think the SIMA server is asking about about the CVD patients, the patient with the cardiac disease who are taking SGLT2 inhibitors without having the diabetes. So, sir, Dr. Ali Meher, please answer this question.
You mean Dr. Saeed Meher, right?
Dr. Saeed Meher, sorry.
Was confusing that is question for me or Ali? Okay.
Because you are
Now,
working in a NICVD, so I think you are answering this very well.
yeah, I agree on that. Now, the SGLT2 inhibitors are not only to control the diabetes, but actually SGLT2 inhibitors are being given that they can prevent the heart failure, they prevent the cardiac complications. So yes, we are using these medications in our cardiac patients, and they are pretty safe in these patients also. So someone who don't have the diabetes, but have got the ischemic heart disease, then this medication will definitely help him or her in preventing him from the cardiac failure. Someone who has got the cardiac failure, for example, then this is one of the ideal treatment for these patients. But definitely, ischemic heart disease patient don't have the diabetes, but still SGLT2 has the role in these patients also.
That's really so nice of you, sir. Thank you so much. I would like also to take your comments about the talk, and then we will going to finish our session. So please, your comments on this talk. Dr. Saeed Meher comments.
Yeah, as I always said, already said, Ali is always a very good speaker. The way he actually teaches with the cases, that's actually really a very good approach for our general practitioner, for our patients, for our colleagues, for our juniors. So I think his talk was, as always, fantastic, very comprehensive, up to the point, and plus main thing is that he actually teaches with the cases, which is the real world scenario. We don't only talk on the words, but the scenarios, which actually patients comes in our clinic. So I think so. His talk was up to the mark, very good, and I hope you all guys have achieved some many insights and will help your patients in managing during the diabetes. Thank you very much.
Thank you so much, sir. You are absolutely right that the talk was very understandable and we learn a lot. So I would like to pay the thanks to all of you, our speaker, our panelists, all the participants who actively took part in our session. And I hope it will be knowledgeable for all the participants. And at the end, I wish a blessed Ramzan and healthy Ramzan to all of us. Thank you so much. Allah Hafiz.
Allah Hafiz, everybody.